Everyone, in today's video, I will be telling you about HOMA index. So let's get started. The homeostasis model assessment is a practical index used to evaluate the interaction between glucose and insulin dynamics. This HOMA index is of two types, HOMA 1 and HOMA 2. The HOMA 1 is based on a simple mathematical approximation of the original non-linear solution to the iterative equations, whereas HOMA 2 has non-linear solutions based on computer model. The HOMA 1 IR evaluates systemic insulin resistance and is calculated by the formula fasting insulin in microgram per ml multiplied by fasting glucose in millimole per liter divided by 22.5, or fasting insulin in microgram per ml multiplied by fasting glucose in milligram per deciliter divided by 405. The normal range for HOMA 1 IR is 0.5 to 1.4. More than or equal to 1.9 denotes early insulin resistant, and more than or equal to 2.9 denotes significant insulin resistance. The HOMA 1 beta percentage evaluates pancreatic beta cell function and is calculated by the formula 20 multiplied by fasting insulin in picogram per milliliter divided by fasting glucose in millimole per liter minus 3.5. The normal range is more than 110% and less than 80% denotes low beta cell function. The HOMA 2 index is a computer model calculating the insulin resistance based on single paired sample of plasma glucose and plasma insulin levels or C-peptides. Computer model gives values for insulin sensitivity, which is expressed as HOMA 2 percentage S, in which the 100% is the normal value and the insulin resistance is the reciprocal of HOMA 2 percentage S. What are the advantages of HOMA index? Well, it provides a good correlation between the estimates of insulin resistance derived from HOMA and from the euglycemic clamp. It can be used to assess the longitudinal changes in beta cell function and insulin resistance in patients with diabetes to understand the natural history and to assess the effects of treatment. The HOMA IR and HOMA beta percentage improves significantly after high intensity interval training on a cycle ergometer or treadmill and sprint interval training by running or body exercise in patients with metabolic syndrome and type 2 diabetes. The molecular basis is that in acute high intensity interval training, there is high GLUT4 translocation, post exercise glycogen depletion, and vasodilator function. And the molecular basis in long term high intensity interval training is increase in the oxidative capacity of the muscle. However, in sprint interval training, there is increased muscle mass used during sprint interval training, which results in greater improvement in HOMA IR in individuals with metabolic syndrome.